yes, that's exactly what I wanted to say. We'll be recording this session, and the session contents would be shared online on the YouTube channel of Guidelines International Network. So if anyone has any concerns or any specific reservations about being recorded, we request you to. Hello. Yeah, we request you to please put off your video if you do not wish to be recorded. So with this, I would like to start this session officially. Today is the World Evidence-Based Healthcare Day. 20th of October of every year is being celebrated as Evidence-Based Healthcare Day, and this is the third year that this event is being organized. In this regard, from LMIC working group of Guidelines International Network, we have organized an online session on evidence-based guidelines in low resource settings about development, adaptation, implementation, and partnership. So this is the brief outline of the session. We have multiple sessions, short lightning type sessions. The main goal of the session is about sensitization of people regarding evidence-based guidelines in low resource settings. It's not a workshop. It doesn't teach the details of the methodology, or it's not a hands-on workshop. It's more of a sensitization and awareness program. Before we go into that, I would like to give a short introduction about our LMIC working group. It was founded in the year 2015 by Joseph Matthew as part of the Guidelines International Network. The main vision and mission of the LMIC working group is to create a platform for sharing issues related to resource-constrained healthcare settings, to develop a communities of practice to enhance healthcare in developing countries, to understand, explore, and to promote guideline development, adaptation, implementation in resource-constrained settings. And we also wish to focus on capacity building at institutional level in low resource settings in the domain of guideline development, guideline adaptation, and guideline implementation. At present, I've taken over as chair for this LMIC working group from Joseph Matthew, who now serves as the board liaison between the working group and the Guidelines International Network. And we have a vice chair, Narasimhan Swaminathan, who's also joined us in this session. The World Evidence-Based Healthcare Day, to just give a briefing about it, it's a global initiative that raises awareness on the need for better evidence to inform healthcare policy, practice, decision-making to improve health outcomes globally. The theme for the 2022, that is 2022 campaign is Partnership for Purpose within and across the global evidence ecosystem to bridge research, policy, and practice in order to realize the potential for evidence-based healthcare. The main importance why we wanted to really actually go into evidence-based guidelines in low resource setting is because in low resource setting, actually, it's very difficult to develop guidelines, implement them, adapt them without actually adequate partnership. Of course, partnership is important in any setting, but in low resource setting, it's of much more importance. So we decided to focus on a theme that is intersecting between the vision and mission of LMIC working group and the theme for this year's 2022 campaign for evidence-based healthcare day, that is Partnership for Purpose. So with this short introduction, I also request you to tweet about this webinar. You could tag me in Twitter using my handle AKIDENT. You could also tag the handle World EBHC Day, or you could use the hashtag. Please tag us so that we know that you're talking about us, and we would also engage and retweet it about it. So at the end of this introductory part, I just want to remind you all that the session is being recorded and it will be shared in YouTube channel of GIN. Please share your questions in the Zoom chat box. Be respectful at all times with everyone. With that, I would like to hand over the session to our to the vice chair for LMIC working group, Professor Swaminathan. So are you there?
Yeah. Am I audible?
Yeah. Yes. And Malavika, are you there?
Hi. Yes, I am.
Yes. Yes, so we have next introductory session by Professor Swaminathan, and Malika would be the moderator. Malvika, you can take over right now.
Okay. Yes, I'd like to welcome Dr. Swaminathan to the stage, and Akhilesh, I wanted to just, am I doing his introduction as well?
Yep.
Okay, so Dr. Swaminathan is Vice Principal Faculty of Allied Health Sciences at the Institute of Higher Education Research in Chennai. He's an adjunct researcher and University of South Australia visiting professor, Bournemouth University in the UK, with more than 10 years of experience as an EBM and guidelines expert, teacher and trainer in EBM and research methods in the fields of physiotherapy. And he is a widely published author, researcher with international collaborations and grant awards to his credit. His core research interests are in cardiopulmonary physiotherapy, evidence-based medicine, and guidelines. And I'd like to welcome Dr. Swaminathan to the stage.
Am I allowed to share my screen?
Yes, yes. You should be able to share screen now.
Is the screen visible?
Yes, it's starting.
Yeah, good evening all. Greetings of the day. So I'm asked to introduce evidence-based practice. This is not the new concept. But anyhow, to start off with, we need to understand the basic of evidence-based practice. That's what my task. So the definition for evidence-based practice, we should be knowing, we all may be aware of this. There are three important components: your individual clinical expertise, patient values and expectations, and available best research evidence. Integration of these three is called evidence-based practice. What we are expected in evidence-based practitioner or evidence-based practice, what we are supposed to do is we are reviewing the evidence which are linked to our question. We analyze it, and ideally we are translating the research into practice. If the research is not translated into practice, we'll not be able to achieve the objective of the research which is carried out. So the process of EBP as documented, it's 5 A's, simple to remember. The first step is asking a question. Ask what questions come to your mind when we are handling our clients or patients from the clinical setup, formulating an answerable question. The second step, as per the definition, we are trying to integrate the best available evidence. So the best available evidence, it should be acquired from the various database by a thorough literature search. The third step, we are appraising the evidence because it should be the best available evidence. We need to consult the best available evidence to inform our clinical practice. So appraising the evidence becomes the third step. And then in the fourth step, we're applying the evidence. And then finally, we are assessing the outcome, whether the evidence works, and then the cycle continues. That's the process of evidence-based practice. There are levels of evidence which are documented. One such as, if you see, the highest level of evidence is systematic reviews with homogeneity of RCTs, and where the low level of evidence is as expert opinion. That's the hierarchy of level of evidence. When we consult evidence, we need to look for the best available evidence. So on this day, which is very important for us to reflect how much we implement evidence into our practice. As Dr. Akhilesh rightly said, the objective of this session is to sensitize people from LMIC about this evidence-based practice so that our patients get the benefit. So what is the importance? Why we need evidence-based practice? it provides the best quality of care. The ultimate goal of every clinician is to provide the best quality care to their clients. So evidence-based practice provides best quality of care. It also improves the patient satisfaction. Our patients are better satisfied if we implement evidence into practice. Another aspect, it also reduces the cost. This is a point where from our LMIC, we should consider implementing evidence. When we started implementing evidence, we will be able to reduce the cost and provide the best quality of care. So in that aspect, the clinical practice guidelines are the one which will be easily adopted or used by the clinicians because they are systematically developed. It is readily available for the practitioners to consult and implement. So this session will provide more insight about clinical practice guidelines. That's what our goal is, to sensitize the people. So with that, I complete my short introductory session. So I hand over to Dr. Akhilesh again. Over to you, Dr. Akhilesh.
Thank you. Thank you, Dr. Narasimhan. Malvika.
Just give me 1 second, please. Okay, so I have the pleasure of introducing our next speaker. And first of all, thank you, Dr. Swaminathan, for the wonderful introduction. Next up is Dr. Radhika. She is from the UCMS College and GTB Hospital in Delhi, India. She is a senior obstetrics, gynecology consultant, and evidence-based medicine expert. She's a widely published author, academic surgeon, and trainer, both in clinical research and evidence-based medicine. She is the national coordinator of FOGSI and the national corresponding editor for the Journal of ONG India, current member. She's an active member of multiple EBM organizations, and she has been awarded numerous awards and accolades, including the WHO Fellow in Domains of the Health Systems. And I'd like to welcome Dr. Radhika to begin her presentation in guidelines in low research settings and its current status.
Thank you so much, Malavika, for the introduction. So it's again a brief, presentation on what is happening, what is today's scenario as of today, what's happening in the LMICs. So at the outset, good afternoon, good evening, good morning for the audience from various parts of the world. So I'm sure my slides are visible. So so why the focus on LMICs? There's been a steady improvement of the healthcare services in our countries. And there is also a very positive change from the mortality to the morbidity statistics and improvement in the quality of healthcare. And with that, we have an improved digitalization, thereby reachability, as well as the spread of the information that's available. And it also is to also ensure, as has been already highlighted by Dr. Narasimhan, that we need a standard, uniform, auditable clinical practice so that we at least know what's happening in our countries. So what's happening in India? It is most medical specialties seem to modify the Western guidelines to suit the local requirements, to suit the feasibility, and there is a lack of uniform standard auditable practice. So how do I say that? We just go through a few presentations, a few publications which has happened recently in the various journals. So this was published in 2017 in the British Journal of Hematology, where they found that the policymakers in LMICs tend to ignore the local research and the results in favor of the research evidence which has been received from the high-income countries. And the usage and the applicability and translation to practice is greatly limited from these guidelines in the LMICs. The sharing of information among the health workers, especially in the rural areas, is limited because of the lack of electricity and internet services. And that was in the year 2017. Today, the situation is much different. And most importantly, which even I, as a clinician, I experience it in various aspects of clinical practice, that the guidelines are not easily accessible. If there is an update, I don't come to know of it. And most importantly, most of the stakeholders are not aware of the way the guidelines need to be developed, how to assess the quality of the various the guidelines that are already available. And this could also be a reason for the lack of trust and the validity of the guidelines. And of course, there are the personal beliefs and local customs which affect the translation into practice. So this was a publication from the oncology clinical practice in Nepal. So this was also, it is highlighted that the studies in the oncology practice in the high income countries may not be feasible. The guidelines are not feasible to be applied in the low resource setting. The next few slides are just to highlight what's happening in other parts of the world. So this is what the Sri Lankan, they did a assessment of all the guidelines that are published with the agree-to instrument, and they found that the methodological qualities of the CPGs which are produced from the low middle income countries are not really good. And this was published, another study which was published in 2021 in the CHEST, the journal. This was regarding the chronic obstructive airway disease. And they also, the authors decided, they concluded in saying that the LMIC should be, the guidelines should be more widely available in the LMICs. They should be transparently developed and they need to be regularly updated. And it is also important to have a thought about the local risk factors, the case findings, comorbidity, and so on and so forth. This was a surprise for me when I looked at the obs and gynae guidelines. This one was a series of publications which were available in the Pakistani website of the obstetricians and gynecologists. They were really very well developed. However, updating was not there, but the presentation was extremely good. This was a publication in 2019. We did a quality appraisal of the clinical guidelines in obs and gynae in India. So what we found was, while the scope and the stakeholders involvement and the clarity of presentation was quite good, it really lagged in the direction of the rigor of development as well as the applicability part. So what was happening was basically people were going through the Western guidelines and trying to modify it to the best possible. Sometimes it was simple copy and paste. So that is why it really lacked the the trustworthiness. So what I would say in short is that there is lack of well-formulated clinical practice guidelines in majority of the specialties in the LMICs. There is poor applicability because majority of them are translated from the Western guidelines, which are primarily designed for the local population from the evidence generated from their countries. And the specialized equipment and knowledge may not be available in LMICs for their translation. And what about the implementation aspect? The publication of guidelines does not really mean that it can be translated into practice, meaning that there is limited implementation that I have already highlighted in the previous slide. And it is also affected by several factors, including the sensitization of the policymakers and the stakeholders, which is largely lacking. I would like to conclude to say that there are various challenges. Lack of awareness is one of the most important aspects. Adaptation of Western guidelines, how the process is to be done, what is the formal process of doing this is not really known to us. Is there a difference between guideline versus the recommendations? Because in my specialty, obs and gynae, it is full of recommendations today. There are very few guidelines really available, and there is these guidelines need to be valid and implementable, and it is important to be for them to be accessible and readable. So what would be the solution? So we need to get together, have a group of interested, committed professionals who are able to get down to the task of learning the process and getting down to developing these guidelines. So training becomes a very important baseline aspect of this process. One also needs to have a continued systemic needs assessment on the guidelines which fit the local environment, and it is extremely important to involve the policymakers and the stakeholders right from the initiation. Thank you so much for the patient hearing.
That was this brings us to the an important threshold, I would say, with respect to this session. We wanted to set the stage as to why this particular topic of guidelines with respect to low resource setting is important. It's because there is a myth that goes on around that adaptation of guidelines is an easy task. There is also a myth that goes around that it's pretty much straightforward because there are existing guidelines, and it's just a matter about rewording it to the local scenario. But the truth is that adaptation is not as simple as it is. It is in fact as resource intensive as development per se. And the second challenge that comes in with respect to adaptation is uh, the the teams that are involved in adaptation. They have to go in for a system, whether it's called as co-creation or a collaborative development of the guidelines and contextualization, because without involvement of the people who are the end users of these guidelines, without knowing exactly what are the barriers, what are the challenges that they face, the guideline implementation would not take off. With this short note, I would like to say that we will be going on to the next stage. Dr. Radhika, I would like
Yes.
you to take over to the next stage. Thank you.
So we have Malavika for the next talk. So I'm really happy to introduce Malavika, who is a guideline specialist, book author, and EBM methodologist and trainer. She's from the Infectious Diseases Society of America, and I can personally vouch for her expertise. We've been interacting in the past few days, and she's very sharp and experienced in the area of. And we're really very happy to have you here, Malavika. She's an expert in establishing collaborations and partnerships with agencies and organizations across the globe. She's been awarded Najwa Milka Cabana, I'm sorry about my pronunciation, Innovation Award by the Guidelines International Network in 2021 for her work in guidelines development with the American Dental Association Science and Research Institute, 2013-21. And she's a steering committee member of the LMIC working group of the Guidelines International Network. So welcome to you, Malavika. The stage is yours.
Thank you so much, Dr. Radhika. I really appreciate the wonderful introduction. Let me please share my screen and then, okay. Can everyone see my presentation? Okay, so hi everyone. I hope you're having a good evening. I am here in Washington, D.C. Actually, my headquarters for my organization are here, but I live in Arizona, which is a state in the southwest of the United States. And I am actually coming to India. I know many of you are in India, so I'm coming tomorrow. So I'm very excited to be on the same time zone as all of you. But for now, I'm joining you from the United States. And I'm going to be talking today about the fundamentals of guideline development, just to set the stage for all of our wonderful presenters coming up after me. So I have no financial conflicts of interest to disclose, but I have been working with GRADE for about 7-8 years now, and I'm a member of the GIN LMIC group as well. So objectives for today include how to formulate PICO questions to, again, set up the stage for guideline development, as well as lead us into the systematic review or evidence synthesis process, which informs guideline development and the formulation of recommendations, how to move from evidence to decisions, and how to formulate recommendations for clinical practice guidelines. So what are evidence-based clinical practice guidelines? What do we actually mean when we say that? So these are a type of policy usually developed by healthcare associations and organizations in collaboration with the guideline panels. This is the panel of clinical and subject matter experts that are actually developing the recommendations in consultation, hopefully, with a guideline methodologist like me, who is helping facilitate that process. Guidelines assist evidence-based clinical decision-making. They're informed by systematic review of the best available scientific evidence. They include consideration of other factors, not only just systematic review results, that are important for decision-making, for the panel's decision-making process, which again mirrors what the target users of the guideline would look like. And these include patient values and preferences, as well as stakeholder perspectives. Guidelines are intended to inform public health programming, and they are designed to improve individual and population level health outcomes and de-implement ineffective and unsafe treatments. So when I talk about GRADE, which is the methodology or framework that we use to develop guidelines, and again, there are multiple frameworks that are used around the world, and if they're rigorous, they're not wrong. GRADE is the most highly adopted methodology, and that's the one I use. So that's what I will be talking about today. So GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation of recommendations, and it is a transparent framework of for developing and presenting summaries of evidence, and provides a systematic approach for making clinical practice recommendations. So it was, again, most widely adopted tool. And it's essentially a framework, a transparent framework, so users of the guideline know what evidence was used to inform the recommendations very, very clearly. So this is a slide I got from the internet. This is widely used by GRADE methodologists in communicating about the work, as well as in training. So this is the big picture of guideline development that we use to move from evidence to decision. So before we collect evidence, we have to understand what questions we're asking. So that's what PICO stands for on the left. We move through the evidence synthesis process. We rate each of the outcomes with a certainty of the evidence, which tells you how certain we are about the estimate of effect and its true value in relation to its true value. And then we move through with the guideline panel through all of that evidence, along with all of the other factors for decision making, and then actually formulate the recommendations. And I'll come back to this slide. I was just wanting to set the stage for what I will be discussing big picture for the next several slides. So there are several papers published in the Journal of Clinical Epidemiology by Dr. Gordon Guyette, who is one of the leaders of the EBM movement, who really started the GRADE working group, along with so many other amazing collaborators. And there's a series of papers that, if you're interested in the GRADE methodology and developing guidelines using GRADE, you should read, and really read. It takes time, but it's worth it because it lays the fundamentals of it lays down the fundamentals of guideline development, which are very, very useful when you're in the midst of trying to organize all of these different pieces of information you need to collect to, again, move from evidence to decision. This is the GRADE paper on framing questions and deciding on important outcomes to inform the systematic review, which then informs the guideline. And this is what I mean by that. So the PICO questions or clinical questions are what many of you are familiar with as clinicians, which is for a patient population, what are the available interventions and comparators, and then what are the outcomes you're looking to achieve by implementing these interventions. And so you're building a comparison, so then you can answer that question or provide clarity on what is recommended based on that comparison in the recommendations. So the importance of clinical questions is immense. They are the foundation for developing systematic reviews and guidelines. PICO questions or clinical questions reflect the scope and purpose of the guideline. They guide the systematic review process. And the answer to the clinical questions are the recommendations. So what should clinical questions look like? So they should be written in PICO format. Patients, interventions, comparators, outcomes. They should include all relevant outcomes required for clinical decision-making, meaning there should be a list of all of the outcomes, both beneficial and harmful, when you're developing these questions, and they should be relevant for the target user. So that obviously requires that you identify who the target user is before you write all of the PICO questions that are intended for your guidelines. So again, PICO questions answer the recommendations. If you don't ask the question, you cannot write the recommendation. So that's very, very important step. One thing I want to note when we talk about target users, the guideline panel should again reflect the target users. If you're developing a guideline for a group of emergency physicians, but it's a dental guideline, which is something that I've worked on previously, you should have an emergency physician sitting on that panel and be consulting with the emergency physician group when you're developing the guideline. Otherwise, you're creating a piece that's going to exist in a silo that cannot be used or is not applicable or is not meaningful to the target users of the guideline. So that's very, very important. And again, building that PICO comparison allows users to know what are the available diagnostic tests or therapies that you're actually talking about, for a specific patient population, and again, allows you to recommend for one of them or multiple options when we're formulating the recommendations. So these are the components of PICO. I'm not going to get into this too much, just wanted to put this up there to again emphasize the importance of being very, very clear and specific and developing an appropriately narrow question. PICO questions are not background questions, they're not information, they're very specific foreground questions that are intended to inform clinical practice. So when we talk about grade and PICO questions, this is generally the format or the framework with which we approach PICO questions and recommendations in systematic review and guidelines. So systematic reviews should not provide any sort of clinical answer, meaning there should be no recommendations provided in systematic reviews. They're simply establishing a question and then the results, an objective presentation of the results of that systematic review. And the systematic review methodology I would recommend you use is that used by the Cochrane collaboration, as well as the risk of bias tools, which I'll mention later, to assess the risk of bias associated with the included studies. So I'm not going to get into systematic review methodology, but I just wanted to put this up just to show you the difference between PICO questions asked in systematic reviews versus in guidelines, how we frame a clinical question, which is, should a guideline panel recommend A versus B, whatever those therapies are, to prevent particular outcomes that are of interest. So that's how you would frame a PICO question in a systematic review versus a guideline. And then again, in the guideline panel recommends A over B for this patient population to prevent XYZ outcomes. So that's generally the framework you use to describe the fundamental question and answer of each of these types of documents. So this is an example of an PICO question that you could establish as part of a systematic review, which again informs the guideline. You are given an example. Let's say a concerned mother takes her son, age 2, to his pediatrician when he develops a persistent cough and begins to have immense difficulty breathing. Upon examination, physician diagnoses a child with severe pneumonia, and the clinician needs to decide on the best therapy for treating the child. So P equals child with severe pneumonia. We may be comparing antibiotic A to antibiotic B as part of our review. And then one of the outcomes we're interested in is mortality. And then other outcomes, because we're talking about antibiotics, could include antibiotic resistance, C. difficile infection. So you should consider all the options, both beneficial and harmful, when writing your PICO question. And then the systematic review, which sometimes includes a meta-analysis. Meta-analysis isn't necessarily always a must in a review. Meta-analysis is run when you can run it, when criteria are met. The meta-analysis results are the results of the systematic review. And you can also do more advanced concepts like network meta-analysis, which again, very specific criteria need to be met to run network meta-analysis. But the benefit of that is you can look at multiple comparisons, both indirect and direct comparisons to inform your guideline recommendation. So it's not just A versus B, it can be A versus B versus C versus D, multiple options. So I wanted to briefly touch on selecting outcomes. So we talked about PIC. When we come to O, or the outcomes, you have to be comprehensive. So benefits and harms included. Patient important outcomes, or outcomes that are important to patients, are the outcomes that you should be using. So no surrogate outcomes if it can be avoided. If you only have surrogate outcomes for a particular condition, then you should use those. And think about the outcomes you need to make an informed decision, not about what is reported in the literature. So if you have a guideline panel and they say, well, we don't have outcomes of mortality reported in the RCTs or observational studies that are available out there. We know all the studies, they're not reported, so we're not going to include that as an outcome. Wrong. Those should absolutely be included. And then in the guideline, you should explain that no data was found to inform these outcomes. So then you have to go to these less important outcomes to inform your recommendation. So then people are clear about what you asked, what you searched for, what you found or didn't find, and then what was used to inform the decision or the recommendation. And the grade approach is an outcome-centric model. It is not based off of the studies you find. So we're never going to talk about this study said this and this study said that. We're talking about an outcome level. So for the outcome of mortality, this is the point estimate. This is the certainty of that evidence. And when considering all of the critical outcomes, this is the recommendation that's associated with the evidence that we found related to these outcomes. So just a big picture overview of why outcomes are so important in the grade approach. So now that you've set the stage for developing the systematic review, the PICO question, you work with a librarian, medical librarian who's skilled in doing systematic or developing systematic review searches, which is a specific expertise. They will run the search, provide you the results. You screen the results based off of a set of selection criteria that are predetermined. You do not make this up as you go along. This is all discussed with the panel from the start. You screen the studies at both title and abstract level. You abstract the data, run the analysis when appropriate. You present the results to the guideline panel, and I'll get into that in a second. But part of the systematic review process keeps going once the results of the systematic review are done, which include writing the manuscript and getting that published. But the results of the review, the meta-analyses, or any narrative results of the review are what are used to work with the guideline panel, with someone like me, the methodologist, who actually brings those results to them and says, okay, let's talk about it. That's the final step of the guideline development process in terms of evidence synthesis and using data. So the hard data. So old systems of moving from evidence to decision would say that randomized controlled trials would inform high-level recommendation, quote unquote, or observational studies would inform a lower level recommendation. And that's not how the grade approach works. What we try to do with the grade approach is look at, follow that EBM model, which is not only looking at the data, but also patient values and preferences and clinical expertise. All of these different factors or domains are important to consider when formulating the recommendation. And the distinction between RCTs and observational studies is less emphasized because, even though it's important, it's less emphasized because we need to know what to do. So to discount a recommendation because there's no RCT would seem like a poor judgment. And so we really want to be transparent about the evidence that's used and mark the certainty of the evidence lower for studies that are more observational in nature because of the bias that's introduced by using observational studies. But nonetheless, that doesn't necessarily mean that an RCT is going to be of better quality, so that it automatically receives a higher level recommendation. So again, this is one of the fundamentals of grade. I can't get into it too much in detail, but I'm happy to answer any questions later. So I'm coming back to this slide because, again, this is the framework for moving from evidence to decision. We've completed our review. We have our evidence profile. Now it's time to work with the panel to formulate recommendations. So we've collected the treatment effects, which are the results of the systematic review. Again, it's an objective presentation of the results of the review. No conclusions are drawn from the systematic review alone. We have assessed the certainty of the evidence of those estimates, and I'll talk a bit more about what I mean by that. And then we also consider things like patient values and preferences as we're going along in the systematic review process when developing a guideline, collecting these patient values and preferences from the guideline panel members or through a focus group or through a systematic review of patient values and preferences is very important. This isn't just me as a methodologist making this up or one person from the panel contributing this information. This should be done in an as systematic way as possible. And we also talk about resource utilization, acceptability of the interventions comparators, as well as the feasibility of implementing these interventions or comparators when we formulate recommendations. So all of this information needs to be collected before we go to our panel meeting to write recommendation statements. So this is an evidence profile. This is what would be presented to a guideline panel when we are in the meeting to formulate recommendations. This is at an outcome level. Like I said, grade is at an outcome level. So you see outcomes of mortality, hospital discharge, and serious adverse events. So this is, again, desirable and undesirable outcomes, and there are likely more. This is just one evidence profile, and this is for the IDSA guideline on treating critically ill patients with COVID-19. So a recent a more recent evidence profile. And so the evidence profile, and again, all of this information is in the grade series on how to develop these, and all needs to go into getting to this point, and the information that actually needs to go in here. So this table includes the number of studies per outcome, study designs, risk of bias associated with the included studies, and then all of the grade domains: inconsistency, indirectness, imprecision, and then the number of patients that were being studied within that comparison, and the relative estimates of effect, the absolute estimates of effect, the certainty and the evidence of that outcome, which is mortality. And this is across all of the studies. That high certainty doesn't refer to one study or two studies. It's for the outcome across all 8 studies. The certainty of the evidence is high, and the importance of that outcome is critical for the decision-making process. So that outcome is important to patients, it's important to the clinician, and is the most important outcome in addition to serious adverse events when making that decision. So that is, the outcomes of mortality and serious adverse events are more important than hospital discharge when formulating that recommendation. So what do we mean by certainty of the evidence? Just want to be a little bit more specific about what I mean by that. A high certainty outcome means that we are very confident that the true effect lies close to that of the estimate of effect, and then the contrast is very low. So again, it tells the reader how confident that they should be when interpreting that result. And I wanted to emphasize that high certainty, again, isn't associated always with randomized controlled trial data, even though what you saw in this previous slide is associated with RCT data. Observational data is sometimes graded up because of different factors. And again, I'm not going to get into it. There's a lot to unpack there, but there are different reasons that observational data can be upgraded from a lower certainty of evidence to a higher based on certain criteria being met. So again, we're trying to move away from RCTs are the only way to go, but obviously use RCTs in systematic reviews if that's possible, because they are obviously a better quality evidence to begin with. And again, in systematic reviews, garbage in, garbage out, it's very, very important that the evidence you use in a systematic review to inform guideline recommendations, which systematic reviews should be used to write guidelines, as specifically evidence-based guidelines. There are other types of clinical policies, but when we're talking about evidence-based clinical practice guidelines, there should be a systematic review involved. Please, garbage in, garbage out, so make sure there is no garbage going in so that you can trust the results coming out. And if there is garbage in the review, it's very important to mark that using very low certainty evidence. So this is a depiction graphic about how we kind of see outcomes during the decision-making process. I had mentioned that adverse events was, for example, a critical outcome for decision-making, raises it up on the thermometer. You should ideally have less than 7 outcomes per PICO question, because the panel can only work with 7 at a time. And then of course the certainty is assessed per outcome per comparison, because that evidence profile I showed you before is for one comparison. There could be multiple questions or PICO questions. So when I say comparison, I mean a PICO question. And then of course estimates for effect for critical outcomes will be prioritized, and the recommendation is the answer to that PICO question, and the strength of the recommendation is based on the lowest certainty of the evidence amongst all critical outcomes. So let's say that the 3 outcomes we're using for a question are mortality, morbidity, anaphylaxis, and anaphylaxis has a moderate certainty of evidence. The recommendation would be informed by a moderate certainty evidence. Therefore, it would have it could go either way, but usually a strong recommendation associated with that, because we have moderate certainty evidence on a critical outcome. So it can go either way, though, depending on all of the other factors we have to use. But generally, certainty of the evidence of the lowest certainty of the evidence for the amongst the list of critical outcomes for that comparison is what informs the strength of the recommendation. So when we're moving from evidence to decision, we've done the systematic review, we've collected the patient values and preferences, we've talked to the panel about their concerns relating to acceptability, feasibility, resource utilization of the interventions and comparators. We need to actually now write the recommendation. So again, more papers available online on how to move from evidence to decision. This is a general framework. Sorry, this slide's a little blurry. Again, I found this from the internet on how to go through this process. So now you have your guideline panel, you have the evidence, you put all of this information into what we call an evidence decision table. And when we talk about adoption and adaptation of guidelines, this is very, very critical because you're developing a guideline from scratch, as I've described until this point. And let's say we want to share the results of the guideline with another group who wants to use the guideline. The most useful thing you can do for them is hand them this evidence decision table. It has literally all of the information I just talked about in this one place. All they need to do is take that table, contextualize the evidence to their resource. Their resources, but also their setting generally. And then that information can be used with their guideline panel to formulate recommendations. So either adopt or adapt those recommendations. So they may say, oh, we don't need to this is perfectly contextualized. We can just adopt these recommendations, or we need to, fix or adapt these pieces. And now we can adapt this guidelines recommendations. So that's why ETD tables are so important. When I say ETD, I mean evidence decision tables. Very, very important. And they help the guideline methodologists like me move the panel from evidence to decision. So we go question by question, outcome by outcome per question, formulate the recommendation, and then bring in all of those different pieces, like what do patients value, what are equity considerations, etc. You generally in having this conversation weigh desirable and undesirable effects. So again, these are results from the systematic review, as well as other information that you've collected. You weigh benefits and harms. You recommend for something usually, or if in the case of harmful treatments, you recommend against something, not just harmful, but that's an example of something you would recommend against to deprioritize a particular intervention that's being used, or that is being discussed about being used in clinical practice. And then you also, again, talk about patient values and preferences and all of those other details. I wanted to just give some examples. So this is from a dental guideline I worked on with the American Dental Association. What you see is a cavity on a child's tooth. We're considering the use of a particular treatment called SDF, silver diamine fluoride. The issue with SDF, though it's very effective in arresting or stopping the cavity from getting worse, is that it turns the cavity black. And so we wanted to make sure that the panel knew that information when we were formulating recommendations. We're not just going to provide a blanket, yes, everyone should get SDF, because part of the recommendation should include that this should be a conversation with the patient, and they should decide if this is something that they are willing to accept when receiving that intervention. So yes, it's effective. Yes, it's very cheap, but they should be able to decide if they want a black spot on their tooth, and they should be aware of that happening before that recommendation is implemented in practice. So this is an example of the importance of patient values and preferences. Part of the evidence of decision framework also includes working with stakeholders. So again, what I had said about target users of the guideline being considered and actually included on the guideline panels is very important. Sometimes all of the people on that have vested interest in the outcome of the recommendations and the guideline cannot be part of the panel for whatever reason. Maybe it's not appropriate for them to be on it, or just would be a poor use of everyone's time for them to be there. They should be part of the network that supports the guideline. So what I usually do as part of the guideline development process is include them from the very beginning. So we invite them to the process, even if they're not sitting on the guideline panel. We inform them of what questions we're asking. We inform them about just, hey, the systematic review is happening. The guideline panel is about to formulate recommendations. Once the recommendations are formulated, I send all those recommendations to a list of stakeholders and say, what do you think? They provide their comments. I bring their comments to the panel. We talk about it. We incorporate some of the things that we think is appropriate. We respectfully respond about things that we can't address or changes we can't make with them. And then we publish the results and acknowledge these people in the manuscripts so that users of the guideline can say, oh, see that, hey, my association was consulted. I can trust this guideline. It's not, again, existing in some silo somewhere without a conversation amongst all of the people that should be consulted when developing a guideline. This is especially important for national guidelines and guidelines that are existing outside of a particular health system. And I also forgot to mention earlier that guidelines are not an individual effort. As you can see, these guidelines that we do here in the United States and across the world are huge projects. So this isn't a solo activity. This is really a lot of money, resources, time, expertise needs to be put together and at the table before developing a full frame evidence-based clinical decision. I'm sorry, an evidence-based clinical practice guideline, because of the complexity of the methods, the resources needed, and the variety of expertise that's needed to be at the table to make those decisions. So I'm going to finish up with what is actually a recommendation. What are we actually trying to do? This is the definition, a clear and actionable statement formulated by a guideline panel to assist clinicians on deciding the best course of actions for patients. So they should have a statement that's clear and actionable. We're not talking about statements like, you may consider X when blah, 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 blah. They're very, very specific to the P, I, and C, of the comparison being built by the PICO question. Sometimes they include the outcomes, but again, a recommendation is of all of the outcomes relevant for decision making. So sometimes it's not useful to list all of the outcomes. And they should also have the certainty of the evidence and the strength of the recommendation associated with each statement. So they use, I've already said all of this. I just want to keep going for the sake of time. So no statements like there's insufficient evidence. And again, they should not be in the context of research, but practice. They should be usable by clinicians that are intended to use the guidelines. So testing of the recommendations is highly suggested. Again, it's not just, there shouldn't be just researchers or these recommendations being written in silos. You should actually talk to the clinicians or include the clinicians on the panel who are using the recommendations so that they can write the recommendations in a way that makes sense to them. Short, actionable, clear. And guideline panels should seldom make good practice statements. Good practice statements are statements like, in surgery, you should, before going to surgery, you should wash your hands. Well, yes, you should wash your hands before doing surgery. You do not really need to write that as a recommendation. And frankly, it's not a recommendation. It's just good practice to do that. And it's a poor use of a guideline panel's time to develop good practice statements using a systematic review of the evidence. Systematic reviews should be, again, used to answer specific foreground questions that are burning questions in clinical practice. If those reviews exist already, you do not need to redo them again. Use the pre-existing systematic reviews after doing an assessment of the quality of those reviews. I can give you tools on what those look like. You should not use bad or systematic reviews to inform your guideline. If there are no good systematic reviews, that's when you actually do a systematic review. This is an example from one of the dental guidelines that I was talking about. This is a recommendation just to give you an example. So I won't read this, but you can see that there's the patient population, the recommendation with the actual interventions that are recommended. We did a network meta-analysis, so we were able to recommend many options, not just one of two. And then the associated certainty in the evidence and the strength of the recommendation. So it's a conditional recommendation, meaning that you should talk with the patient. You should consider other factors when making the decision. A strong recommendation means just go for it. Conditional or weak means we need to think about some other things before we go for it. So this is an example of a tool that was developed after the recommendations were developed. This is an algorithm. This is a slide from an old presentation. So again, we're laying out all of the information from the systematic review and guideline recommendations. The recommendations should be easy to digest. Yes, there are publications that are put out, systematic reviews and guidelines, but then you should also consider tools like algorithms, chairside guides, for the patient pages, videos, podcasts, all to disseminate the recommendations in a way that's usable and current. PDFs, giant PDFs are no longer a great way to communicate. No one really wants to read a 500-page paper. So again, you should display the evidence in a transparent way because that is important to the grade process, that for all of the recommendations, you should know what evidence is linked to those recommendations. And you can see footnotes here that kind of get into that. And you can't see the whole algorithm, but all of that information is there. That way people know the panel didn't just make this up. Evidence was used to inform all of this information on this slide. Again, the work I did with the American Dental Association before my work with the Infectious Diseases Society of America was part of a great network of collaborators. And that's really how you should see the work that you do in guideline development. This isn't again, a solo activity. This influences so many different people. So really consider who should be at the table and use information that's already out there. Don't feel the need to come up with all of it on your own. It's absolutely not necessary. So in summary, grade and guideline development is a systematic and transparent framework that should be used to develop guidelines. All factors relevant for decision-making should be considered and presented at the time recommendations are formulated by a guideline panel. Work with the methodologist to do this work. They know they will help you. They will get you to that end. It's a lot of work. And I don't think this is for the novice. This is not something that should be attempted from scratch. So please consult with the right people. All evidence and judgments used by guideline panels should be available for users. So evidence profiles, evidence decision tables, systematic reviews should all be available so that people know how you came up with the recommendations. They should not just exist without any explanation. So thank you so much. That's it for this presentation. I'm happy to answer any questions. I am so sorry. I am in the habit of putting my old email address on slides. I just transferred to my new job. I will put my new email ID in the chat. Thank you so much.
Thank you, Malavika, for that exhaustive introduction to the process of guideline development. We are actually running a little late, so we would like to have your questions in the chat box and we will address them. And we have our next speaker. I'd like to go ahead with the session because our next speaker is joining us from Australia and it's actually close to midnight. So I'm sorry that we are actually going a little late, but thank you for being there. Professor Narasimhan, I would request you to introduce the speaker and lead us into the next session.
Once again, good evening all. Our next speaker is Dr. Janine Margarita Tyson. She's a researcher and EBM methodologist. She's an expert in research synthesis and conceptualization of reviews, clinical practice guidelines. She's very passionate about complex interventions and translating knowledge into practice in various settings and economies. She has hands-on experience in developing guidelines for some of the low income countries, and we are happy to have you here. Welcome, Dr. Janine. We are looking forward to hear from you.
Thank you very much for that. Hello, can everyone hear me?
Yeah, yes.
Hello. Yep. All right. Thank you. Yes, thank you for that very nice introduction. Let me just share my screen so I can start with the presentation. Oops, sorry. All right. So where's the share? Okay, I'm just sorry. Right, share. There you go. All right, can everyone see my screen now?
Yeah.
Yes.
All right, thank you. Okay, so from the beginning. All right, so I'm here to talk about guideline contextualization processes in low resource settings. I've been a guideline methodologist and methodologist for about 10 years now. And I've been involved in de novo guidelines, so developing guidelines from scratch. And then also involved in a number of adapted and contextualized guidelines. All right, so let me begin this. Okay, so I'm just fiddling with my screen, sorry. All right, let me begin the presentation formally by acknowledging that I am doing this in the traditional custodians of the land from which I'm speaking with you today, the Kaurna people, and pay my respects to the elders past, present, and emerging. All right, so the first few sessions talked about clinical practice guidelines, how they are used in practice, how they're being developed, and most importantly, I think for tonight's session, the issues that LMICs have about clinical practice guidelines. Okay, I think it's all clear with everyone that CPGs or clinical practice guidelines are a sort of one-stop shop for everyone, so clinicians, managers, policymakers, to search for guidance in practice. And guidelines or CPGs are usually available online, so they're really accessible. You don't need to have access to databases. The only thing is these clinical practice guidelines are usually lengthy and come in hundreds of pages, which sometimes makes it really difficult for people to go and navigate, especially when they're needing that information in a very short span of time. Okay, I'd like to highlight the issues about guidelines or CPGs in low resource settings, which previous speaker, Dr. Radhika, actually covered. And these are actually relating to the lack of existing guidelines, specifically for low resource settings. Also, I think one of the reasons why there is lack of guidelines for low resource settings is that there's lack of expertise. So there's a lack of methodologies in LMICs, and therefore there is lack of guidelines. And then also there's lack of funding. We know that developing de novo guidelines are very expensive. It's time consuming, so there has to be dedicated time and funding, which unfortunately low resource settings do not have. And then in terms of what's available in the published literature and the guidelines, there is limited applicability. So I think most of the issues around low resource settings are focused on the applicability and transferability of the information or the recommendations in guidelines into the settings where clinicians or managers or policymakers come from. Now, there has been a lot of discussion in the last 10 years about using developed guidelines from elsewhere and applying the recommendations in the settings of low resource settings. And most of the discussions before were about, okay, so it's really difficult to apply the findings or the recommendations because of the differences in settings. And I think you all agree about that. And most of the time, what people would say, okay, let's just develop our own. But then when they get to that point where they say, let's develop our own, they stumble across all these challenges about funding, expertise, etc. And so now there isn't any way to go. So that's very disheartening. But let me tell you that it's actually good. And I think that was highlighted as well in the presentation just before me, that there are existing good quality work already that's been developed. And I think, and this is based on the work that I've done as well in low resource settings, is that the focus should be on how to actually implement what the recommendations, especially recommendations which are strongly based on high and good quality evidence, and focus on how this can be implemented into local practice. So if possible, we shouldn't be recreating the wheel because we only have limited resources, we only have limited capacity in LMIC. So we might as well use those remaining resources, those remaining energy and expertise into something that's more implementable in practice. So essentially what I'm saying is that if there are good quality guidelines, then it's actually reasonable to use them and apply them in practice. But the question is, how do you know actually whether these guidelines or the CPGs are of good quality? All right. So there's a way to assess the quality of these guidelines, and you can use the Agree tool, which you can see. You can see the URL in this slide, and it's freely accessible as well. It's been developed to assess guidelines in the most robust way, or for those who don't actually have that much time, because it takes about 30 minutes to an hour to use, depending on the skill of the user. We have developed with my colleagues previously the ICA tool, which is from the International Center for Allied Health Evidence, which is as good as the Agree to tool, but is more efficient because it's shorter, and it's actually for those who don't have that much time to spare, because they're busy clinicians, they're busy managers, and they're busy in the work that they're doing. And again, the URL and a link to that tool is available in this slide. And I'm happy to send everyone a copy of that if that's something that makes it a lot easier. All right, so we all agree that it's actually useful, and it's also best practice to make use of existing clinical practice guidelines, which are based on comprehensive and systematic reviews of international evidence, as what's been discussed previously as well. Now, if we're sure that these are good quality guidelines, good quality CPGs based on our assessment using Agree to or the ICA tool, and we know that they're current, so if they've been published in the last 5 or 10 years, and the work has been done by credible groups, organizations, professional associations, then there is really no need to develop another one. All right, so I'm highlighting this because it's also best practice to take stock of what's out there, but again, only if you're sure that it's current and it's of good quality. Okay, so this is a screenshot of the page where we've developed a guideline decision-making tool. So it's sort of an algorithm to present to you how you go about in terms of whether, you decide to do a de novo guideline, or whether, you need to just do an updated guideline, or you actually need to adapt or contextualize. So obviously, the first stage is you would have to have an interest on a condition or a question that you need answered. So when you've got that, you search for existing clinical practice guidelines. Now, if you find one or more CPGs, then you assess the quality and the date. So again, this is using either Agree or the ICA tool, and look at how recent or how old that guideline is actually. Now, if you find one that's out of date but of good quality, maybe what you need to do is an update of that guideline, or maybe look for an updated version, because the developers of those guidelines might have already been in the process of updating. So you just have to look for the updated version. Now, the other path is, if let's say you found an up-to-date guideline and it's of good quality, so the next step is decide whether you adopt the guideline, adapt, or contextualize. And this is what I will be talking about in the next slides, okay? Now, the other possible scenario is you actually find an out-of-date guideline and also, unfortunately, a poor quality guideline. So in this stage, you're stuck because you actually need to develop a new guideline, all right? Now, if let's say as well, this other path in here is that, when you did a search, you found no clinical practice guideline that answers the question that you need answered in practice, then obviously there's no way to go but, develop de novo guidelines. And developing de novo guidelines is what has been discussed in the previous session, okay? And again, this is accessible via this URL. All right, so I did mention that I will be talking about the alternative methods to guideline development, and this is based on the work that I sort of have been doing with different partners in LMIC settings, and was also part of the postdoctoral work that I have done in South Africa a few years back. And this is the ACA model. So it's an alternative approach to using existing good quality evidence from clinical practice guidelines and putting the recommendations into local practice, because essentially that is what LMICs need. It's that implementation of the recommendations in the local practice, looking at local context, looking at the barriers, etc. Now, this ACA model, so ACA stands for A is adopt, C is contextualize, and A is adapt. So the differences between these are adapt is, as we all know, is to use without any change. So when we adopt a model or a framework or any guidelines specifically for this discussion is, well, it means that we are readily using the guideline without change because the recommendations are readily applicable in practice without any further contextualization. Now, when we talk about contextualization, essentially what we mean is that we're using existing good quality CPGs, but not changing the recommendation because the recommendation is relevant as it is. But what we need to address are the locally relevant strategies to assist local implementation. And I'm going to talk about this in more detail in the next slides. Now, adapt to us is actually, when we say adapt, is changing, okay? And this happens at times when existing CPG recommendations are not directly relevant, and that there could be some other local research happening in the LMIC setting, which when we integrate that, the recommendation may actually change, all right? Okay, to make that simple, I would like you to refer to this figure, and this is something that I really like to talk about. And think of it this way. So if, let's say, for instance, there is a suitcase. Okay, so suitcase is obviously needed for traveling, and at this stage in time, we are able to travel again, which is really good, you know, after the pandemic. Well, it still is there, but, you know, at least we're able to travel. And now I think it's time to get those suitcases out again. Okay, so if we are traveling and we just need a suitcase to pack our stuff, and we don't need to change anything with the suitcase, that's essentially what adopting means, okay? It's just borrowing that suitcase or taking that suitcase in the same condition, same purpose as it is. Contextualize, on the other hand, is taking that suitcase because we need a suitcase to pack our stuff, but then while traveling, we want to make it locally relevant. So we want to know where we travel. So then we put those travel stickers, okay? But the suitcase is still the same. So in the context of CPGs, what this means is that the recommendation, if it says it's a strong recommendation for a treatment, then that strongly recommended treatment would still have to be applied, okay? But the contextualization occurs in terms of where it's happening, who is delivering the treatment, and all of those more local context issues. Now, adapt is more of, you know, changing. So because there is a different source of information, or in this particular scenario where we're talking about the suitcase, you need a specific purpose for that suitcase, because while traveling, let's say, for instance, you got tired, okay, and you needed somewhere to rest, and there wasn't anywhere to rest, and so you've converted that suitcase into a chair. And now it's not really the suitcase that it was before. And in relation to CPGs, this is when the recommendation would change from a strong recommendation to, let's say, a weak recommendation because of additional research that has been found that now changes the recommendation itself. And because of that, there would be other changes happening in terms of implementation. Now, we've published this paper, and the reference is in here, so you can just check that. And if you want to read a bit more about the adapt, contextualize, and adapt model. Okay, so since this session is about contextualization, we focus on that particular method. So when we talk about contextualization, we take the product as it is. So we take the recommendations as they are coming from the guidelines. And the thing is, there might be more than one guideline actually that you can find that provides answers to the questions that you've raised. Okay, and specifically because there are guidelines published in different countries, there are guidelines that have been published in high resource settings. So you would expect that there could actually be more than one, okay? But most of the time, they would be saying the same recommendations because they would be summarizing the evidence from the same evidence base, the same systematic reviews. There could be differences in the way they present the recommendations. So some would use level A, or some would use wording such as strong recommendations, okay? But essentially, they're just saying the same recommendation. So when we talk about contextualization, we focus on how to put those recommendations into the context of where it's going to be applied. And usually this relates to either the language, the workforce, training, resources available, communications happening, or if, let's say, for instance, protocols or algorithms may have to be developed to ensure that they are implementable in local practice, okay? So what are the steps to get to that stage? It's essentially similar to the steps in developing de novo guidelines, where it's, you start off with searching, but in this case, instead of searching for systematic reviews, you search for existing current CPGs for the condition of interest, or if there are specific questions that you want answered. And then you look at the quality, okay, assess the quality. And then when you are sure that it's a good quality or high quality guideline, you extract the relevant recommendation that answers the question that you want answered. And then after that, you apply the ACA model in terms of saying whether, you can readily adopt the recommendation, no change at all as it is, and applicable to the local context, or whether you need to contextualize or adapt. Now, just a note, when you are contextualizing, because you may find more than one CPG, you may need to standardize the recommendations. And I will show you an example of how we did that in a very comprehensive guideline that we did for South Africa for stroke rehabilitation. Okay, these are sort of guides. So the next slide presents to you some of the guides that we actually use to assist in contextualizing the evidence. And usually it relates to the economics. So, from high resource to low resource settings, okay? Workforce, who's the available workforce? Have you got a multidisciplinary team, or are you limited with just one or two specialists in the team? What about the health systems? Is it funded by the government, funded by a private hospital, or in terms of the way the health system runs in that particular setting? Management options that are available, access to care, and also very importantly, the patient types, because usually in low resource settings, there are cultural variations or cultural beliefs as well. And these reflect the type of patients with the condition. And these are very important to consider in contextualization of the recommendations. Okay, I'd like to highlight this, and that's why I've got this in bold in this slide, that if evidence is relevant, okay, but there are local context issues which usually refer to health service delivery concerns that challenge applicability, then the most appropriate method, I'd say, is to contextualize the evidence. Okay. All right, so this is now the example. If, let's say, for instance, you're interested about management of stroke patients as soon as they are admitted to a hospital, and the most recent recommendations that I actually found in this year are coming from the Australia New Zealand Clinical Practice Guideline for Stroke Management, which says that all stroke patients should be admitted to a hospital and treated in a stroke unit with an interdisciplinary team. Okay. And the other one is from NICE from the UK, which says admit everyone with suspected stroke directly to a specialist acute stroke unit after initial assessment. All right. And this could either be in the community or the emergency department or outpatient clinics. Okay. Now, the important recommendation here is that of the acute stroke unit. Okay, and it's defined as a unit that is discretely in the hospital and is staffed by a specialist stroke multidisciplinary team. And the unit should have access to equipment for monitoring and rehabilitating patients. Okay, now this is what I'd like you to think about. If you were in this particular scenario and you're thinking of the best guidance for stroke patients, okay, coming in the hospital, what do you think would be your concerns coming from an LMIC setting? Okay, would there be a dedicated stroke unit? Okay, would there be a multidisciplinary team to assess the patient? Okay. I'm pretty sure you would say if you are coming from an LMIC setting is that in some cases there would be, but unfortunately it's not across all settings, correct? All right, okay. So, and that's exactly what we found when we were doing the stroke guidelines. Okay, thank you. I received, or I saw that there was a thumbs up about that. So yes, it's a issue that we're faced with, you know, when we are in low resource settings. And so what we've done from the South African contextualized stroke guidelines is that we searched for guidelines, you know, to answer that question. And interestingly, you can see here that we've identified more than 3 CPGs, which are of high quality, and they all say the same thing. And so we just had to standardize the wording because some of them had or used, you know, level A as grading, some used wordings as strong recommendation, and some used plus to say those are strong recommendations. But essentially, what they were saying, and this was across all, okay, that there are consistent strong recommendations that patients who suffer from stroke should be referred to a multidisciplinary stroke unit as soon as possible. Okay, and there are consistent suggestions that a multidisciplinary acute stroke unit should include the following health professionals, and that includes a physiotherapy and occupational therapist, a speech pathologist, a dietitian, a clinical psychologist, and a social worker. Okay, now think about your setting again. Okay, do you have access to a multidisciplinary stroke unit? Okay, if you say yes, then that's good. Then this could be readily adaptable. But if not, which is usually the case, we'll have to contextualize. And how did we contextualize? So we sort of had discussions with the policymakers and the end users in terms of what were the barriers that were actually existing for hindering the implementation of that recommendation. And so what they said was, if you look at this barrier section here, is that not all levels of care have access to a multidisciplinary team consisting of the following. Okay, so what were now the suggestions that we got? Okay, and this all it's detailed in here. The suggestions to overcome the barrier in here was that the available member of the multidisciplinary team should assess a stroke patient. So the available member depends on the setting. Okay, so if there was a doctor in there or there is someone who's trained, then okay, they can do the preliminary assessment. And if not, a referral pathway should be in place to allow the stroke patient to have access to the specific member of the multidisciplinary team and at a facility where the service is available. Okay. All right. So does that make sense? I hope and I guess most of you will agree that, this could be a pathway that you'd also be taking if this was the barrier that you identify in a setting. All right, just another example of a barrier in here. So not all stroke patients will have access to a specialist multidisciplinary stroke unit, okay? Not all hospitals will have a dedicated stroke unit. So what if you don't have a dedicated stroke unit? What do you do? Okay. Where a stroke unit is available, of course, a patient should be assessed and admitted to that unit. However, if it's not available or the patient does not fit the criteria, then the patient should have access to a multidisciplinary team for care, which means that it may not be in a specific unit, but it could be that in the hospital, they could set up a place where they can have that team or the essential members of the team do the assessment and provide the care for that stroke patient. Okay, so essentially what we're saying is that there are barriers, but there are ways on how to deal with that by contextualizing what the evidence actually recommends or strongly recommends. Okay, and just a few more slides, I think. What prompted those suggestions in here to overcome the barriers are two methodologies. First is a parallel assessment, okay? So these were the contextual factors that we've identified from the people that we were working with. And then what we did was to look at what the retrieved evidence coming from the existing CPGs actually are reporting, about these factors. And then we ask them what the current or what their own setting actually have in terms of all these contextual factors, because that's a good way of sort of comparing and seeing what you actually have in your setting that will now allow you to contextualize the recommendations in practice. Now, the other method that we use is actually this more detailed prompts, which we call them prompts, where again, the left-hand side in here is all about the contextual issues, that the LMIC settings would actually be concerned about. And we've mapped them against several strategies in terms of, let's think about what is exactly required to make that change. And it's actually difficult. So we said to them, it was difficult to think about that because, when we want to create change, it can open, a whole can of worms. So what we thought would guide them in thinking was to think about, if you have, if these are the context issues or considerations, what do you think is available in the minimum standard of care or in usual situations? And we can take stock of that. So let's say, for instance, in that, using that example about stroke units, if we talk about resources and type of workforce, then, if there is a space or in the hospital, or, they can reorganize the hospital, for instance, where, they could put all the stroke patients in one area, then, that's a good start. You don't need another building just to have a stroke unit, okay? So whatever is existing can be modified in that sense. Now, who are the healthcare professionals available in your setting so that we know who can actually do the assessment and management of the stroke patients, okay? Now, we also asked them to think about, because in some settings, they have more than what's just the minimum. And so in higher standards of settings or care, they can have a dedicated stroke unit in more maybe sophisticated hospitals, which is good. And they could have more access to a specialist. And then that's also good. So which means if that's available, then there are no issues. But what exactly is the concern in low resource settings usually is this minimum standard that's available, but actually which are helpful and easily modifiable if we just want to apply the evidence in practice. And then the last column in here is about training, because this is good for planning in the future. There could be training design, there could be training resources that are available, or in the future, there could be training available for other professionals or policymakers to access elsewhere. So in order to implement the recommendations more in practice, okay? So essentially, the CPG implementation considerations that contextualization involves relate to the following, and I think you would all agree. This may not be exhaustive, but this is actually what we got from the people that we have been working with. And these are the main considerations when we're contextualizing to ensure implementation of recommendations in low resource settings, okay? All right, so lastly, this is just to give you a list of CPGs that have used the contextualization method. So there have been 5 guidelines from the Philippine Academy of Rehabilitation Medicine. And I think 2 or 3 of them have already been updated as well. Then there is 1 or actually 3 guidelines from South Africa, and 1 is on stroke, 1 is on chronic musculoskeletal pain, and 1 is on pre-hospital guidelines. And then we're still working on a project that is also using contextualization method in South Africa, and this is for childhood immunization. So it's improving childhood immunization. So watch that space. And thank you very much. I think I've exceeded, but I hope that was worthwhile as well. And thank you, and have a good day. And it's 12 midnight in here now. Thank you.
Thank you, Kenyan, for the quite an exhaustive presentation again. And again, we have our next speaker already aboard. So we know we are going a little late, but I would like to fast forward into this. I would like to introduce the next speaker, Nagwa Kamis. She's head of the IPC department and CEO consultant in CCHC hospital in Egypt. She's emeritus consultant of clinical microbiology at Ain Shams University. She's an expert in epidemic outbreak management, as one of the WHO consultants in multiple outbreaks during the H1N1 outbreaks, and as well as the Ebola outbreak in Mali, and also the recent COVID-19 outbreaks. She served as a board member in IFSC, and she's also the honorary secretary in the past. She's a trained infodemic manager. That's how actually I met her during one of her training, and she's a coach and trainer in evidence-based medicine as well. I just wanted to invite her to present the challenges in guideline implementations in low resource settings, considering her expertise and experience working in very low resource, or I would rather say resource poor settings. Nagwa?
Yeah,
Over
thank
to
you.
you.
Thank you, Akil, for this nice presentation. And I would like to share my presentation from my laptop now, because I added just 2 slides more. So it's okay. Great. So maybe I will go a bit fast because we are short of time and I have a meeting. Yeah.
Nagwa, just 1 minute. Your voice is a little low.
So like this is better?
Yeah, it's better now.
Okay. So I'm just saying that I will go a bit fast because we are a bit short of time. So I will show the challenges in guideline implementation in low resource settings. First, I should declare no conflict of interest. To start with, evidence-based guidelines are the most important documents for incorporation of scientific evidence in health decision-making through the formulation of recommendations. So shortly, guidelines are a set of recommendations. Generally speaking, the characteristics of any guidelines, they are developed with a thorough methodology, multi-centric controlled studies, a systematic search of scientific evidence to support recommendations, and they are facing some problems in their implementation, like multiplicity, conflict of interest, approach of multi-morbidity, patient involvement, and quality indicators. We will take just a few of the problems facing the implementation of the guidelines. This is again in general for healthcare professionals usually encounters various sources of information or guidelines developed, whether by government agencies, by local scientific societies, or by recognized international institutions, and that's why we are obliged, while formulating local guidelines or implementing them, we have to adapt and customize them to our local situation. The conflict of interest is mainly related to key opinion leaders. This may affect the decision making or the formulation of some guidelines. Multi-morbidity means that usually guidelines are monomorbid, which means when we are approaching the treatment during the clinical practice to a patient, we just find guidelines related to a certain disease. But if we have a patient with multiple diseases, we have to collect the information from multiple guidelines. Patient involvement, adding patients' perspectives, this might pose a problem in low middle income countries, because we know well that there is a problem of illiteracy. Quality indicator or the good practice indicators, again, is sometimes we consider this an option and not a standard of clinical practice. So, however, clinical practice guidelines are not recipe books, as they may have limitations in their availability and applicability in local context. Focusing on developing countries, we always believe in don't limit your challenges to challenge your limits. So we have to work with our tools. We have to face the challenges and we have to sort them out. For guideline formulation first, we do just search in other guidelines published as reference, especially in the field where I am professional, the field of infection prevention and control. So as guidelines, we have the CDC or WHO, or locally we have the Gulf Committee guidelines. We can search in specialized textbooks and references like the Basic Concepts one of the International Federation of Infection Control and others in the same specialty. We can customize foreign guidelines to the real status of local healthcare settings regarding the supplies, the education, and the culture. And sometimes we customize other regional guidelines. Unfortunately, we don't have local research to write our guidelines de novo. So we are taking the guide from other guidelines or them, and in Syria this is the updated guidelines. The major problem will be in the implementation. So before starting the implementation, we have the guidelines in hand. Commitment with the implementation. We don't believe that we can work with instructions, with recommendations. We like always to work with our mind. So we call this mind lines, not guidelines. The homogeneity of implementation. Even in the same country, you launch the guidelines and they are in hands with professionals. you will find each organization is working with the guidelines on its own way. So there is kind of heterogeneity or non-standardized implementation of the guidelines. Then comes the big problem of lacking the resources. First, to have the skilled professionals to implement these guidelines. Then comes the supplies, and always I intended to put the human resources first, because without human beings we cannot work, even we have the what we need from the supplies. And the third is the technology, because nowadays we cannot go further without the recent technology. Then after starting the implementation of the guidelines, we may face still some problems like miscommunication. We have the book in hands, we don't communicate with each other to collaborate for the implementation. The trust and engagement with other healthcare worker, and here I mean when we are working with guidelines of infection prevention control specifically, because I have this experience in my field. We have the recommendations with references, everything in reference to standards, and our partners in other departments, they don't believe in what we are trying to give them as awareness or training. And sometimes there is absence of leadership support, and I mean by this the administration, the high management, because without their support we cannot go further with the implementation of the guidelines. So I try to give some highlights about this issue in our region specifically, and as an example of the low middle income countries. I hope I could give this summary about that topic, and I may have like 5 minutes to take some questions if you have. Thank you very much.
We can't hear you, Akhilesh.
Hello?
Yeah.
Yep.
We didn't
Okay.
hear you.
Yeah.
You were muted.
All right. So, it was actually a very succinct presentation, Nagwa Khamis, and really nice of you to have summarized those points, the pain points that are there in implementation of guidelines in low resource settings. And, as we have just been seeing in different scenarios from different speakers, one was
Yeah.
the involvement of the stakeholders, the end users, the people, or the patients, or whoever is going to be the beneficiaries. And here we also have an important aspect about involvement of the leadership, which becomes very important with respect
Yeah.
to working in low resource settings.
Mm-hmm.
So with these key concepts that we have gathered right now, I would like to go forward. And if there are any questions, we would request you to please put it in the chat box, because some of our speakers are from different time zones. And like I said, it's already midnight, and Nagwa is actually heading out for another meeting.
Yeah.
So if there are questions, please put them in the chat box right now, or you could also share them later, and we would summarize some of the important concepts or the doubts together with you in an email at the end.
So, thank you, Akil. Thank you very much.
Yeah, thank you, Nagwa. Moving forward, I would like to introduce Dr. Abha. Abha is the mother of a 14-year-old boy, nature lover, pediatrician, and right now she is a non-resident fellow at Center for Global Development, and she is also working with International Decision Support Initiative. She has specific experience, interest, and expertise in capacity building and system strengthening for development and implementation of clinical practice guidelines in clinical governance, quality improvement, and data-driven decision making, especially in low resource settings such as India, Bangladesh, and other places. She has also been a faculty. She is a faculty for Institute of Healthcare at IHI and supporting healthcare QI, I mean, quality improvement initiatives in Southeast Asia across different countries. She has previously served as consultant to NICE, World Bank, Imperial College London, and Access Health International. She's a Fulbright scholar and she's a certified IHI improvement advisor and an EBHC. Dr. Abha, we would like to invite you to speak about the importance of partnership. Partnership purpose is the theme for this year's EBHC Day. And as we have already seen, partnership and collaboration among different stakeholders is very important for guidelines in any setting. And this becomes very important in, when we are working for guideline development, adaptation, and low resource settings. With this, I would like to invite Abha to present her views on this. Dr. Abha?
Thank you. Thank you very much, Dr. Akhilesh, for the opportunity. I know it's quite late in the evening, so I'll be brief and hope to finish my presentation early. I'll try my best. So I'm speaking from my experience working in India, and I want to illustrate a few examples of partnerships that we have had with various stakeholders to move towards developing more systematic, transparent guidelines. So this is not a comprehensive review, but just a glimpse of, and this is not comprehensive of all the partnerships that are currently in the country, but just it's an illustrative of some of the partnerships that I wanted to highlight. So the first thing I would be speaking about is the work of IDSI. So IDSI is an international decision support initiative, which is a global network of health policy and economic expertise working to achieve universal health coverage. IDSI has institutions, as you can see in the schematic, which are across the globe, across Latin America, Europe, Africa, as well as Asia. And we work in partnership with countries to bring long-term institutional capacity. I think that's very important because it needs to be sustainable for priority setting and sustainable UHC, which includes practical support as well as capacity building and building knowledge products. IDSI's initial work in India actually started at the state level and on developing quality standards for maternal health, which were derived from locally available clinical guidelines on maternal health. But later it moved to working at the national level with the Ministry of Health by participating in a national task force, which in 2014 the new government had set up because there was an anticipated launch of a national health insurance scheme called the National Health Protection Scheme, which actually 4 years later got implemented in India by the name of PMJY. At that time, the task force was asked to look at the plethora of existing guidelines in the country and come up with recommendations of which guidelines could be trusted and recommended to be used while implementing the National Health Insurance Scheme. And the task force faced all the problems that we heard earlier, that often guidelines in LMICs, it's very hard to assess them using any standard framework like the agreed framework, because there is very little information available in the process that was followed and how those guidelines were developed. So the task force agreed that instead of assessing existing guidelines, it may be best that we come together to put together a methodology on how transparent, rigorous adaptation of guidelines in India can be done. And this was published by the Ministry of Health and the National Health System Resource Center. And using the methodology of 14 guidelines were tested. The methodology was tested, developing 14 guidelines, which were developed by 10 guideline development groups at that time. This guideline program moved from the National Health System Resource Center to a different house in ICMR and Department of Health Research. And later, because of the COVID pressures over the last 2 years, I believe this program is currently paused. Having said that, we have continued to work and now working more with the professional organization. So IDSI currently has a partnership with the National Cancer Grid. It is a network of cancer centers, research organizations, and patient groups across India. And with the secretariat at the Tata Memorial Hospital in Mumbai, one of the key areas of mandate for the NCG is to develop uniform standards of cancer care across the country, with guideline development being one of the key areas of focus. Also to add that India has in 2018 launched the National Health Insurance Scheme, which is called PMJY. And there is an MOU between the National Health Authority and the NCG And recommendations of cancer care provided under the NCG guidelines are aligned to be taken by the network hospitals of the National Health Insurance Scheme. Another key point is that these guidelines are resource stratified, and I'll be talking a little more in the subsequent slides, and the implications that has when we're taking decisions on what gets included in which tier. So they're resource stratified and are divided into essential, optimal, and optional. The optional is defined as one which would, of course, reflect the state of art, and the recommendations are based purely on the available clinical evidence, but without any consideration for cost effectiveness. The optimal recommendations are those which are based on both cost effectiveness as well as the clinical evidence, which takes into consideration the implementation aspects in terms of existing infrastructure to implement the recommendations. And then essential recommendations are those which are based on evidence, are practical, and offer value for money. And as I mentioned earlier, these cancer guidelines are directly linked to the health benefit package of the National Health Insurance Scheme and are used to guide both the claim authorization as well as the final claim settlement. So the NCG had been developing clinical guidelines even before Center for Global Development and IDSI partnered with them. But there was an acknowledgement that we needed to have a more transparent and explicit approach to how the guidelines are developed. So there was an agreement to develop a manual on how going forward the NCG will develop cancer guidelines, and the next updation, which is going to happen in 2023, is going to be using the methodology which has now been published and it's available on the NCG website, which is the NCG Guidelines Manual. This manual helps the experts from the different centers use a consistent approach, creates a platform for professionals, patients, and other stakeholders to work together. And it's a reference document that is updated and reviewed in line with the evolution of the guidelines. We've recently published a paper on the process followed in developing the guidelines manual, which is cited in the slide. I'd mentioned earlier that the NCG guidelines are tiered, and I think there is often this problem when we are developing recommendations to be included in the guideline, that how do we balance between the fact that there are limited resources, there are unlimited wants, and how can we, especially when the government is reimbursing care, how do we ensure and allocate scarce resources to improve health, and every unit of money that is spent, which can be spent only once, is providing value for money. And health technology assessment is a useful tool. It's a multidisciplinary process that uses explicit methods to determine the value of the health technology. And the purpose is to inform decision-making so that the recommendations that come out are equitable, efficient, and high quality. While cost effectiveness is one of the criteria that's considered in an HTA, it also looks into other aspects like equity, implementation, patient acceptability, and some guideline developers, and we do know NICE is a very good example, do take into account cost effectiveness evidence while making recommendations within clinical guidelines, which can then further be distilled into quality standards and then implemented using financial and non-financial levers like the Universal Health Coverage Scheme. So keeping that in view, and India does have a health technology assessment program, which was established in 2017, and we do support that program as well. But there is an acknowledgement that there are existing challenges to even doing HTA in LMICs, similar to the challenges that we talked about in doing adaptation of recommendations in terms of limited capacity, dearth of cost data, as well as epidemiological data, and sometimes an HTA can take up to 1 to 2 years. So we have worked with the NCG to develop an adaptive HTA methodology to use in LMICs, which is a pragmatic approach which leverages available evidence. There is no current global standard on HTA methods. And the HTA methods that we have used, we hope that that's contributing to the literature around possible ways in which adaptive HTA can be done by clinicians. And not only have these been published, but the NCG guidelines manual links the use of economic evidence and how it is to be considered when the guideline development group members are making recommendations. Also want to add that the NCG guidelines manual, and I heard earlier a lot of discussion about adaptation. So we have used the right adaptation checklist as a framework while providing guidance on how to report when adaptation of recommendations is being done from existing guidelines, so that there is greater standardization, there is a more robust process when we are adapting the recommendations, as well as there is greater clarity and explicitness in the way the recommendations are worded. So currently we are working, as I mentioned, the manual got published in last year in 2021, and we are currently working in training the guideline development group members of the NCG on the methods that are there in the manual. And the next updation of the NCG guidelines, which is expected in 2023, will be as per the new methods. The training is being provided, and again, this is about the network and the fact that we collaborate with so many partners, is being done by a faculty who is the leader for Agri collaboration and is also working as a professor in University of Antigua in Colombia. In addition, we're also working to build capacity within the guideline development group members on the use of HTA in decision making, and are providing training which is led by the Institute for Economics as well, IECS, which is present in Argentina. And there is also training being provided, practical on-hand training being provided on adaptive HTA. There have been more than 10 adaptive HTAs which have been completed using the methods that I mentioned earlier. And they directly link to implications for what gets reimbursed under the National Health Insurance Scheme. I also wanted to mention one more collaboration that's happening in a different interspecialty, which is in ophthalmology. So NICE International is collaborating with the LV Prasad Eye Institute in India for the Eye Hope project. They initially worked in sensitizing them and sharing the experience from NICE by delivering a series of knowledge transfer seminars, providing an introduction to how NICE develops clinical guidelines, quality standards, and indicators. The IHOPE has a secretariat, and both NCG and CGD have been invited to be there in an advisory role, but they also have representation from the All India Ophthalmology Society and university partners, PGI Chandigarh, as well as the national insurer, the National Health Authority. And currently there is a second series of knowledge transfer and capability building seminars going to support them in developing a guideline on diabetic retinopathy. And again, there is interest in how can we use economic evidence, use HT and adaptive HT, and take that into consideration when these guidelines are being developed. So I'll pause here for reflections and questions. Thank you.
Thank you, Dr. Abha. This brings us another one more important player into the field, about the lack of evidence with respect to, economic evidence, which becomes, in fact, whenever there requires to be a guideline or any recommendation or any program that needs to be rolled in, the first question that comes up from the leadership is about, okay, how much is it going to cost? And how is it going to be funded? And how is it going to be sustained after, say, 3 years or 5 years? What's going to happen to it? So as far as India is concerned, that's a very big lacuna with respect to lack of, economic evidence. I see, Radhika, you have something.
So
Yes.
So I think that was a very good presentation, Dr. Mendratha. It was very informative. So I just wanted to share with you, we have not been introduced earlier. I work as an obstetrician gynecologist at Delhi at the University College of Medical Sciences. And I was very closely involved with the Pradhan Mantri Jan Yojana, the medical insurance for the obstetrics and gynecological procedures. So that is where the guidelines in the HTA, we were told to put a price to the various procedures and to see whether they are optional, desirable, and essential. So we just had to do an experiential, way of putting anything there, to actually price the procedure and all that. So we did a random survey of what is happening in the private sector and vis-a-vis what is happening in the government sector and try to find the mid balance. So I'm just trying to highlight that big organizations, especially our country and the partners like your good organization, should probably also consider training people like us, who are going to be deeply involved in the policies of the government. And because it has got long-term implications, what we put a price on also reflects in the way the hospitals behave. I put a price to a simple procedure, a certain amount, then there is a change in the practice in the corporate sector. So LMICs have got a different kind of a challenge. And I think today training is extremely important. And you highlighted that very nicely. So thank you so much.
Thank you, ma'am. Thank you. And to add, ma'am, I mentioned the course on use of HTA for decision makers, which is largely clinicians, policymakers, which is being done by Institute of Clinical Effectiveness in Health Policy. So we have reached out to the NHA to nominate people from the guideline development group as well as other policymakers in their system to attend the course. So I'm happy to share, talk to them and share the link with you. It's going to start in the month of November. So
I
I
would
think that
really
might
be
be
interested. So if that was possible, I would be probably the first one to get in.
wonderful to hear that.
Yeah.
Thank you, Dr. Abha. And Dr. Radhika,
Yeah.
actually,
So
see, there was one more speaker that we have who's not listed in our list. We had invited them, and they just been available. So, Dr. Radhika.
yeah, so I'm happy to welcome Dr. Ashu Grover from the Indian Council of Medical Research. She's a scientist F in the medical specialty. She's a Deputy Director General, Senior Grade at ICMR. She oversees the departmental health research activities since 2008 and has more than 20 years of experience in implementing large-scale public healthcare programs, health system strengthening and NCDs. And she is a important person and she is really driving the development of the standard treatment workflows for common conditions for UHC. And she is a close friend, a very hardworking person. I'm very happy to have her here. And she would like, we are now also in the process of developing an updated version of the standard treatment workflow. So she would like to share her experiences also. So, Dr. Ashu, over to you.
Yeah, thank you so much, and a very good evening to all of you. And thank you, Dr. Radhika, for introducing me to the group. Even though I'm not listed, but it's always better to be sometimes go unmentioned as well. But I think thanks to organizers to give me a chance to speak on this platform. I'm sorry I'm not visible because I was waiting in my office room to come my turn, but then I came to my office back and I'm in my vehicle. So sorry for my poor video and all
So
that,
we
but
can
I
hear you
will
well.
make my
Yeah,
presentation. Yeah,
sure.
Thank you so much. So I will share the presentation and so is it visible?
Yes, we can see it.
Yes.
Okay. So one and all, thanks for giving opportunity again. So what I am going to tell you about that we had started an initiative of developing standard treatment workflows. This was a mission mode activity which was the felt need by the Department of Health Research as well as from the National Health Authority and World Health Organization India country office. So the need was felt that we have all the lengthy guidelines procedures, as we have been listening from the Australia partner and previous other speakers also, that there are 100 pages guidelines and we have the very difficult clinical decision support methods, and some of the physicians are quite inducted and practicing in the government service as well as in the private services for so long. So they must have forgotten, and they're having their own methods of treating the patients at the OPD setting or at the IPD setting or even at the emergency settings. Even at the emergency care settings also, some of the procedures which should have been followed up, they're not being followed up. Reason being because they have no time to go to the updated version, and if they have some time, they have some guides or some PhD dissertation, they're so much lengthy. And other reason that different committees also have their own process, academic associations and all that. We came up with the Clinical Establishment Act also, where there are certain variations and all that. And now Dr. Radhika knows that at association like FOGSI has different guidelines, and some state federations or OBG colleges, they may have different workflows. So what the methodology, the issues in following up these guidelines were that there are, they meet the standards, they are evidence-based, they are based on certain, information which is already there and experiences and all that, but still it is very difficult to get it implemented. And we had been listening from the speakers in the previous slides. We have the NICE, which Abha has mentioned that, yes, they're also working for the UK government, and they have come up with a very beautiful guideline packages, around 195 or maybe more than that, maybe there. We have, in Australia, yes, we have the National Health and Medical Research Council. They also develop guidelines. Ministry of Health Ghana has STG document, which is 288 pages, which is of 12 specialties. So similarly, the WHO and United Nations organizations and other country partners, they also have, the different versions and lengthy guidelines. So with the growing new scientific evidence and as applied to the low and middle income countries like India, we have the, very less, doctors sitting over, large number of the patients. There's a huge rush in the OPDs and the clinics, IPD and the emergency department. So the time spent per patient is very less. So whatever patient comes up and whatever comes to the clinician minds, he gives the medication or the treatment or a management as per his own standard classic treatment way of, handling the patients. So definitely physicians who are treating the patients at various levels of healthcare, they require a simplified, updated approach, which is ready reckoner, and it is in the form of a very concise document. So this is a standard treatment workflow. The beauty of the standard treatment workflow is it is a one-pager concise document. It can be utilized at any levels of healthcare setting. Even a primary care physician and as well as a tertiary care level physician, even if it is a neurosurgeon, must also go through that one-pager document, which has been developed by the Indian Council of Medical Research. So the primary goal was to develop these workflows to empower the physicians. It's only for the physicians. We don't have any paramedical healthcare workers. It is to make a clinical decision workflows for common conditions, for serious conditions at IPD, and ED department. And definitely these workflows, as because NHA is a partner with us, NHM is also our implementing agency with us. So these guidelines, these workflows are facilitating the Ayushman Bharat and PMJ arm of the NHA, and they are being quickly rolled out into their, the packages. So what is the structure? So we have the ICMR standard treatment workflow team housed in the ICMR headquarters, and we have the advisory committee under the chairmanship of Director General ICMR, and with members from WHO, United Nations, NHA, NHM, and we have the specialty experts and we have the domain experts. And after these workflows have been prepared, we have the editorial board, which goes through very, minutely, and the outcome of every treatment workflow is either in the form of a book, it is either in the form of a mobile app, or it is available on the web portal. So this is the summary that we have prepared, released 3 volumes, volume 1, volume 2, volume 3. Volume 1 was in 2019, and after that pandemic struck in. So in the picture which was released, the first volume was released by the Niti Aayog, the WHO and the NHA partner, you can see in the image. And volume 2, when activity was resumed, we got a request from the Central TB Division to develop the standard treatment workflow for specifically dedicated to the tuberculosis, and they really wanted some workflow to be. Yes.
Dr. Ashu?
Yeah.
Dr. Ashu, 1 minute. Sorry to interrupt. The slides aren't moving forward.
Is it?
Yes.
None of them?
No.
Okay.
Ashu, put them in the slideshow board, no? Would you like to?
I will not put it in the slideshow mode then. I'm so sorry. I think I will not put it in the slideshow mode.
We heard you well, so there is no.
Okay.
Yeah, we heard you well,
now?
actually.
Yeah.
Is it moving now?
Can you put it full screen? Yeah,
is
it's
it moving?
Yeah, it's fine.
It's moving. So I think I won't put it in full screen, Dr. Radhika. I don't think so it will move again.
Okay, sure.
Okay. So, okay, I think I will resume where I left. I won't go back. So what we have developed 3 volumes, volume 1, volume 2, volume 3. And I was in volume 2, which is specially dedicated to tuberculosis. And it is having 18 conditions, including extrapulmonary tuberculosis and pediatric tuberculosis and the microbiological workup and the drug side effects of the liver side effects and the kidney side effects of the ATT. Third volume was recently released in the last leadership with Dr. Bhargav. We had 11 specialities. So total we have 122 workflows which are available in these 3 volumes. These are the conditions in which we have developed the standard treatment workflow. It is a 1-pager document. It is starting from signs, symptoms, brief workup, what to do, what not to do, when to refer the patient, and brief investigations and very outline of the management. It is not something novel, which is a new thing has come up. So whatever has been happening till today in management of, for example, I'll go to the workflow as well. See, for example, in obstetric, we have the, antenatal care and cesarean section. In pediatric, we had the pneumonia. In psychiatry, we had the depression. So all these conditions are already available. So these 122 workflows are available with us. And who has developed these workflows? We have the experts. We constituted the specialty expert committees. We have been taking all over the country. The experts have been taken up. They are from various associations, private healthcare providers, World Health Organization, primary care physicians are also, because they know that what is the deficiency in the Indian public healthcare system. So they say this is not available. For example, we want to go for a cataract surgery. Cataract can be diagnosed, but it can be operated at a little higher setup. So what basic minimum investigations they can do. So the idea behind developing STW was that the patient who has come to a primary healthcare level at least should not go unattended. He should be given, if the facilities are available at that level, he should be given up some. So this is the volume 3. We can see again the Niti Aayog, the offering, patent, and the NHA partners who have released the latest volume. And we have the mobile app. I think it's very easy to download on the mobile app. How the app works is you have go to the Google Play Store, just simply mention the standard treatment workflows. It is downloadable, and you can see the entire condition. So this is the volume 1, volume 2, volume 3. They're available on the website. Now, these are the pictorial representations of the 3 workflows. On the extreme left-hand side, you can see the rational use of topical medications. This was one of the standard treatment workflow which dermatology people was very keen to develop it. And they have mentioned the dosages, that how these topical medications are, overutilized. And the starting from left-hand side on the topical medication standard treatment workflow, some brief description about, because this is a very small font size, and because one slide, but if you see, it is a A3 size poster, and it can be printable, it can be pasted on the walls, and it is downloadable on the mobile app as well. In between, we have the neonatal hypoglycemia, and I think if I take you to the journey of how these have been developed, so the experts who are
Sorry
preparing
to
these
interrupt,
workflows.
Dr. Ashu.
Yeah.
Actually, we have the time limit was set for this Zoom meeting. So I think
Okay.
we'll
Okay.
just,
So I will just
yeah.
quickly tell that, so these are you can just download it. So key feature is it's 1-pager, all in one. It is app based. It's only for the physician, but this is not a legal binding. This is the advisories. These are the expert opinions, and it has taken to develop one treatment workflow. It takes around 10 to 15, days to develop, because they brainstorm that what to put, what not to put. So we are planning to take it in operational research mode to find out its utility at primary healthcare and the secondary healthcare. So this is a diagrammatic representation that how we have developed. So it is a lengthy process to come up with, and we have all the experts' opinion. We are trying to put it through conferences, seminars, and the webinars, and very soon we will be starting the webinars also. So those attendees out, we have 17 over here. If they can, I can keep the slides, share the slides. They can scan this QR code, and they can be easily downloadable. And these are very simplified approach for management of common conditions at various levels. Thank you. And again, my regards to the organizers to listen to my talk, and any questions I will ready to answer.
Thank you so much, Dr. Ashu. That was extremely informative and I think very relevant to the present audience. Everybody, we all have been striving hard to go in a certain direction. It's great to know that, now we can work together. So over to you, Akhilesh.
Thank you. This brings us to actually the end of the session. We have had, kind of, it was a fast track event, but we have tried to cover up the base. We know where we are with respect to guidelines in low resource setting. And the absolute beauty of the session is about even bringing awareness about existing work that's going on, work that is in pipeline. And we have managed to bring in some, groups of people who are working at the helm of these affairs, about creating these guidelines and implementing them at national level. And my special thanks goes to Dr. Ashu for making time to actually come and join us, because we actually wanted somebody from the leadership and implementation backgrounds, and that was one of the reasons why we wanted to bring in such speakers, so that we have an idea about it, or we get people on board, and people who are interested in such work would actually have an opportunity to bring in and maybe know where to connect, who to connect with, and how to go forward. So with that, I also have, I know that we did not have an interactive session here. We did not have time for having a lot of questions, but I believe when this presentation is also shared over YouTube, we'll have more people actually understanding what's going on in India and in other LMIC settings. Just to bring this to a close, I would also be sharing the feedback form to the presenters. To those present here, if you're present here, you could scan this QR code and go into this feedback and share your feedback on the sessions. I also would like to acknowledge the Guidelines International Network for supporting us with this session, and our board liaison vice chair, the steering committee members of LMIC. I would like to thank everyone who have been through helping me with putting this, the entire program together. The experts who have made in their time from different time zones, from Australia to Egypt to India, and joining us at quite unearthly hours and in between meetings and conferences to make time for this. And I thank the audience who have been patiently here, though we have actually kind of exceeded time, but still being around with us. It's a motivation there. And I would like to acknowledge the support given by my institute, because they have been supporting me to allowing me to actually work, to spend time in arranging such events and such. So without their support and motivation, this would not be possible. Just to bring this to a close, the official partners for World Evidence-Based Healthcare Day have been different organizations involved in evidence-based medicine across the world, including JBI, Cochrane, Campbell, GIN, NICE, CEBH, and Institute for Evidence-Based Healthcare, along with principal sponsor by a publisher there. And before we just close, I just want to remind you all that, please give in your feedbacks in this regard. And if you have any questions, you could also add it up in the feedback form, or you could send it in through you could Twitter me in my account at AKIDENT. We would also be sending you further communications and sharing the links to the YouTube as well as other materials which are shared by the speakers to you over to your email. If anyone has any, Dr. Radhika, Dr. Narasimhan, or anyone else have any parting comments, closing comments in this regard?
I think it was an interactive meeting. It was good to meet the speakers, know so much about what's happening. And so now we are left with 14 participants. So special thanks to people who have waited till the end. And thanks, Akhilesh, for leading the way and meeting Dr. Narasimhan for the first time. Nice meeting you here. So we look forward to further such, informal meetings again.
People who are online, just for a second, if you could just put in your videos, people who have actually stayed back with us, if you can put in your video so we could just have a screenshot, have a kind of a selfie kind of a thing. I'll just count till 5 and then before I go in for a screenshot. 1, 2, 3, 4, and 5. I'm clicking a screenshot. Thanks everyone.
Thank you. Good night.
Thank you.
Thank you.